Okay, so we're streaming live on Facebook as well. Welcome everyone. We're waiting for a few more people to log in. Thank you for attending. This is a Kenya Association of Pediatric Dentists webinar in association with the Federation of Special Care Dentistry based in India. We welcome each and every one of you. We would like to encourage especially the Kenyans to join the Kenya Association of Pediatric Dentists. It's open to everyone, general practitioner, dental specialists, not only necessarily pediatric dentistry, but even those doing cons, pros, perio. You're all welcome to join our association and help it grow. Membership fees 5,000 Kenya shillings and 4,000 Kenya shillings for the undergraduate and postgraduate students. It's also open to undergraduate students, interns. We welcome each and every one of you. Karibu sana. We're just waiting for a few more minutes to settle before we can begin. We've been joined by a lovely team from India who are co-panelists and also speakers for today. I can see we have Dr. Rushika, an oral physician and radiologist. So welcome, Dr. Rushika. I think today we'll have a bigger audience from India. I can see someone from Saudi Arabia. We also have guests from all over Africa. So we'd also like to welcome them, those from Tanzania, Uganda, South Africa, Zimbabwe, Ghana, Nigeria. You are all welcome and thank you for sharing our webinars support and logging in every week. We have tried to have weekly webinars, and thanks to all of you and your participation, you have made this possible. So a few more minutes, give a few people to log in. Right now we are at 160 attendees. We are streaming live as well. So for those who have not been able to log in, they can view this on our Facebook group and shall also be uploaded on our website, kapd.or.ke, but I shall share this on the chat box. Any questions geared to the speaker, kindly put them on the Q&A section. In the chat box, you can give us your names. You can all tell us where you are from so we can see the variety of attendees that have logged in. So the Q&A section specifically for questions to the speaker, and then chat box, you can communicate with everyone else in the group. So currently we're at 170, maybe a few. I can see Dr. Philip from Nigeria, Dr. Kapoor from India. You are most welcome and thank you for joining. I will share this. This is on Facebook. The Facebook group is called Kenya Association of Pediatric Dentists, and on our website, www.kapd.or.ke. But this will be shared on the chat box very shortly. CPD points will be available to the Kenyan participants. This will be automatically fed into your ICPD portal for those who registered correctly. Yes, Dr. Mujalid, we usually see your posts on Telegram. Thank you for joining. This is recorded, and if you want, I can share it with you, and maybe you can also share it on your Telegram group. There's usually a global pediatric dentist group on Telegram. I hope most of you are logged on. Let me just confirm the name. It's usually called Global Pediatric Dentists, and Dr. Mujalid is usually active on the group and usually shares our videos there. So welcome everyone. I think right now we're at 186. So I will introduce Dr. Manesh Lahori from India, a member of the Federation of Special Care Dentistry. He's been a past president of the Indian Society of Pedodontics and, sorry, that's Dr. Goyal. So Dr. Manesh, would you like to introduce Dr. Namineni?
Yes, I'll do that. So good evening, everyone, and we are here, the fourth lecture web series by Kenya Association of Pediatric Dentists in association with Federation of Special Care Dentists, Dentistry, and the topic for today is Nitrous Oxide Inhalation Sedation in Dental Practice. And To do the honors, we have a renowned and eminent speaker from India, Dr. Srinivas Namineni. So before I hand over to Dr. Srinivas, I will have the honors to welcome Dr. Srinivas. Dr. Srinivas did his bachelor's and master's in pediatric dentistry from the prestigious Bapuji Dental College and Hospital, Davangere in 1994. He was professor and head of pediatric dentistry from Vikarabad, Telangana, and he has a vast experience of 20 years as teaching. And he's heading the clinical pediatric dentistry department in the prestigious Rainbow Children's Hospital at Hyderabad since 1999, and he's got passion for special needs dentistry. He's got numerous achievements to his credit. To name a few, he was the past president of Indian Society of Pediatric and Preventive Dentistry, one of the first members of International Association of Pediatric Dentistry from India. He has been the member Education Committee of International Association of Pediatric Dentistry. He has got more than 30 publications to his credit and has contributed his experience in 3 textbooks. He's acclaimed as pioneer in propagating and training nitrous oxide oxygen inhalation sedation in India, and is one of the pioneers in it. He's trained over more than 2,500 dentists in India and abroad, formulated guidelines for Dental Council of India and Indian Society of Pediatric Preventive Dentistry. He's a managing committee member of the Indian Organization of Rare Diseases, and he's an ardent voluntary blood donor and is due for his 68th time, primarily for thalassaemic children. It's an honor for me to welcome you, Dr. Srinivas, and it's all yours. So you can mesmerize everybody by your wonderful presentation.
Thank you very much, Dr. Manish, for your kind words. And I'm honored to be here presenting on this topic. Am I audible enough?
Yes, please, you're audible.
Yeah. Hope my slide is visible. Is my slide visible?
Yes, it is.
Good. Pujambo. That's namaste in Hindi. The gesture of namaste has got more relevance post-COVID because it is one kind of wish where you simply do this without touching anybody. And it doesn't matter whether it's morning, evening, or night. And whether you are wishing an elderly person or a younger person, all are going to be honored by simple namaste. And this is being followed by many people across the world because this is one of the safest ways to wish people during this COVID pandemic. And somebody wearing the mask used to be very annoying probably till last year, but today if somebody doesn't wear the mask, they are going to be annoying everybody else. And that's going to be the new norm for us. Yeah, I'm honored to be addressing Kenya Association of Pediatric Dentists and warm wishes from Federation of Special Care Dentistry and from many colleagues across the world in India. And it's a nice gathering. It's a nice experience to be addressing people across the world without moving out of our houses. Thanks to COVID, there are many things which we have explored. This is where I am now. This is where I am now. And this is where somebody else, and there are people across the globe. Now people spread all across the world. Dr. Manish and Dr. Priya, they're all here. Sorry?
The slide is not moving, I think.
Okay. Am I on the globe?
No, you're on the first slide only.
How about now?
No.
Excuse me a second. Is it fine now?
Yeah, it's visible.
Very good. Yeah, just to give a visual idea of where I am and where you are and where the rest of the people. And this is where Dr. Manish is going to be. This is where he is, and this is where I am, and this is where the Kenyan Association is going to be, and there are people all across. Yeah, COVID has taught us many lessons. One lesson is that we have learned how to learn many things without moving out of our houses. And in fact, we are going through an information overdose. We have been attending many webinars and many lectures across this period, and I'm sure many of us have reskilled with many aspects of dentistry because of the COVID. And thanks very much for the COVID for giving us this opportunity. I think it's not moving.
No, sir.
Will be muzzled, will be a problem. Well, that's what he's going to try to do, but there's millions of scientists, there's thousands of scientists out there, like here at this great hospital, that don't work for him. Their job doesn't depend on him. That's not.
How about now?
Just try
Yes.
moving it to the next slide, because just change the slide, please.
I'm going backward and coming ahead.
No.
Yeah.
Is it moving?
No, it's stuck at that globe only now.
It's happening for me. I don't know. I think, shall I rejoin the... Any luck here?
Just try changing it. Yeah, it's moving now. Just move. Yeah, it's
Yeah.
going.
Going to. Yes.
Yeah. Culturally, I think the culturally Kenya and many African countries are quite similar to the way we behave with children. In India, punishing a child for the good behavior is acceptable. I don't know what the culture says in African countries, but I understand that many things are quite similar to our country. That means even in Africa, punishing a child with a good intention for the good behavior is acceptable. I think this is the input I have got from many colleagues. The context is that there is a change in the parenting nowadays. We do not try to be harsh on these children like how we were before. The things are changing, days are changing, the cultures are changing, and the parenting is changing. So this parental change has made the dentistry in particular, dentistry in general, and pediatric dentist in particular, to introspect that should we change and what kind of learning we need to do from the changing parenting. And this article is one of the first articles to focus on this aspect, that should pediatric dentistry change the way how we were handling children. This is the introspection which is happening across the world. That means we are more compassionate, we are more empathetic, and we are more caring for children than how we used to before. Similarly, pediatric dentistry has changed significantly than how we were before and how we are now. We are more compassionate. When a parent do not raise voice at their children, as a dentist, I should not be raising voice at my children. So with this demand, the parent is going to step into our clinics. And this aspect is going to be much more when the child has any kind of special needs. This has made the dentistry and pediatric dentistry in particular very challenging, where we have been traditionally practicing behavioral management and behavioral shaping techniques for a long time. Now that we are using less and less of those behavioral managements. I mean, when there are about 10 to 15 behavioral management techniques, we don't use them all, but we have selectively used few of them, like tell, show, do, or voice control. These are the 2-3 behavioral management techniques which we use nowadays to manage the behavior of the children nowadays in our clinics. And added to that, we are using more and more pharmacological means to manage the behavior than ever before. So that's the major change. That is the major phenomenal change what has happened in pediatric dentistry, how it was 2 or 3 decades ago and how it is now. The demands, the expectations, everything is changing from the parent as far as their child's dental treatment is concerned. So it is time, it is a wake-up call for us. It is a wake-up call for us to wake up and give that kind of a comfort, give that kind of a confidence to the child and the parent, so that in the child's view, the child is not going to look at the dentist as a devil. We are going to be much more empathetic. And with this context, we use we need to handle the fear in the child. We need to handle the fear in the child with an objective of avoiding unpleasant and unproductive confrontations with the child, and create an environment that will facilitate the development of the child's confidence and allow the dentist to carry out the procedures with the minimal disruption. So that is the reason why we have to handle the fear. But ideally, we should be using behavior management and behavior management alone to handle this kind of childhood. But how about a child extremely fearful or extremely anxious? And how about handling a child with the disabling conditions? Can we still stick to behavior management and get that expected results? I'm sure everybody will agree that we need to go a little beyond behavior management and look for other options what we have available with us. It's not different with adults too. If some of you are practicing adult dentistry, if you look at, many adults avoid going to a dentist simply by the fear, not because it is expensive or not because it is inaccessible or any other reason. The only reason many adults avoid going to a dentist is simply the fear of a dentist. If you look at the literature, look at the adults who are afraid of going to a dentist. All this is going to precipitate to a lot of neglect, and the adults will suffer from debilitating dental conditions and change their quality of life. And said that, looking back to our practice, did we ever give a choice to the patient? Did we ever ask the patient, can I give you a local anesthesia without pain? We never asked the patient about it. We always took them for granted. We always prepare them that there will be a little bit of pain with the local anesthesia. You have to bear it. And that is how we've been handling these patients. But if an option is given to you that do you want a shot with pain or without pain, then obviously the choice is always going to be a shot without pain. That is where we need to look at little beyond behavior management, little beyond managing a person with a simple cajoling them. Now, with this context, we are looking at nitrous oxide oxygen inhalation sedation in ambulatory dental practice as today's topic. When I say ambulatory dental practice, we expect dental practice to be using nitrous oxide in a dentist clinic without help of an anesthetist, and that is how the nitrous oxide is going to be used by dentistry. We are going to learn a lot more about this in further course. Who needs nitrous oxide oxygen inhalation sedation? NOIS stands for nitrous oxide oxygen inhalation sedation. Who needs? Number one, every age group coming to dental practice will need some kind of behavior management and some kind of sedative.
Wow, habari yako?
I'll request everybody to mute themselves, please.
Oh, okay. I thought my cartoons are speaking.
Okay. Imagine mimi niko mzima hata na corona. Tunashukuru tu. Tunasema tu hatuko.
Oops. Okay. Yeah. Am I audible now?
Yes, you are.
Yes,
Sorry.
you are.
Good. Every age group of patients, whoever walks into practices, will need some kind of help from pharmacological management of behavior, be it a child or be it an old person. Every age group of people will need some kind of a help from a drug which is going to calm them. And more so, if it is a child or if it is a little older people, they will need little more help from pharmacological behavior management. And not ignoring the fact that we do have many children who come with the disabling conditions and handicapping conditions. They also do need some help from pharmacological agents in terms of sedation so that they can control their emotions and reduce their fear and give that part of a behavior so that we can deliver the treatment in a most comfortable and fear-free way, how they will enjoy the treatment. And when we talk about which procedures need sedation, almost every procedure in dentistry will need some kind of sedative. I would say wherever there is an element of fear in that procedure, probably they need either behavior management or something beyond behavior management like pharmacological behavior management, like nitrous oxide oxygen inhalation sedation. That means whether it is an endodontic procedure or a pediatric dental procedure or a prosthodontic procedure or an implantology procedure or orthodontic procedure, any procedure wherever there is element of fear is involved, we need to reduce the fear. And the best option for reducing the fear is in the form of nitrous oxide oxygen inhalation sedation. So it is a misnomer that we keep thinking that it is the pediatric dentists who need the help of nitrous oxide inhalation sedation. But in fact, any dentist, whoever is practicing, can get a great advantage of nitrous oxide oxygen inhalation sedation in their practices. Like how you have a dental chair in your practice, it is a good tool to have a nitrous oxide sedation machine in your practice so that you give the best advantage for nitrous oxide for every procedure and to every age group of the patients who walks into practices. Now, the first question what you might have in your mind before starting listening to this lecture is sedation safe? That is what we've been worried about all these years and decades. And we are going to start with a couple of slides. These slides basically address how safe nitrous oxide is going to be. To start with the first slide, there was never been a death happened because of nitrous oxide ever reported across the world, as long as nitrous oxide is being used by a dedicated dental sedation machine, when nitrous oxide is used alone, and when nitrous oxide is not added with any other sedative drug. As long as we stick to this 1, 2, 3 rules, that means as long as you use nitrous oxide, and as long as you use nitrous oxide with the dedicated sedation machine, as long as you use nitrous oxide alone, as long as you do not add a second drug to the sedative drugs, there is no way you can have a person who would be threatened to the life. What more do we want? So now we are going to learn about nitrous oxide, without that threat, that nitrous oxide is going to be dangerous. Yeah, many people will not learn about nitrous oxide or fail to learn about nitrous oxide because they're afraid that nitrous oxide could be dangerous to some people. No, because it is not. I am telling because there is no reported case ever reported across the world in the literature or anywhere else about any death happened because of nitrous oxide. Yes, probably you would have heard of a couple of deaths or few deaths because of nitrous oxide. That is not because of nitrous oxide. It is only going to happen when you breach these three rules. When you add the second sedative drug to the nitrous oxide, then there is a possibility of the safety of nitrous oxide is lost. Then there is going to be a threat to the life of the patient. So there is not going to be any danger to the patient as long as you use nitrous oxide. When you use the machine, use nitrous oxide alone and do not add any second additional sedative drug to it. Hope everybody would agree with that. We'll touch upon a couple of definitions. That the first one is about conscious sedation. Conscious sedation is a term used to explain a technique in which the use of the drug or drugs and produces a state of depression of the central nervous system, enabling the treatment to be carried out, but during which the verbal contact with the patient is maintained throughout the procedure. That means from starting to end, when you use a sedative for delivering the dental treatment, all through the procedure, the person should be able to respond to your verbal command. That means when you ask him what is your name, he should be able to tell your name. When you ask him raise your left hand, he should be able to do that. If you ask him to raise your little finger on the right hand, you should be able to do that. So he should be able to respond to you meaningfully, and that is the bedrock on which the whole concept of dental sedation is going to be. So at no point of time you should lose this verbal contact with the patient. So as long as you do that, and there is not going to be any issue with nitrous oxide or any form of sedative for that matter in dental practice. But you need to maintain this verbal contact throughout the dental procedure. Deep sedation is a little beyond that, where there is going to be a partial loss of protective reflexes, where you don't lose protective reflexes in conscious sedation. That includes the inability to continually maintain the airway independently or to respond purposefully to physical stimulation or verbal command. So when you get into the deep sedation, the person will start losing the protective reflexes and person will stop responding to verbal commands, and you may have to purposefully stimulate to make him awake. Whereas in conscious sedation, if you simply ask him, hello, Srinivas, get up, that means he is going to get up. Whereas in deep sedation, there should be a purposeful stimulation physically. Only then the person is going to be aroused from deep sedation. We're not going to talk about general anesthesia, but symbolically, general anesthesia is where you lose all the reflexes, and it is going to be the airways need to be maintained, the respiration need to be maintained, the person is not going to be responding to any even a noxious stimuli, and verbal command is not going to be responded to. That is where an anesthetist is going to be taking care of the physiology of the child or the person. So we restrict ourselves to conscious sedation, and the objective of nitrous oxide is entirely to fix yourself in the state of conscious sedation. And there is something called anesthesiology, continuum in anesthesiology, where it talks about minimal sedation, moderate sedation, deep sedation, and general anesthesia. This is the scale on which a person can move from minimal sedative level to general anesthesia based on how much drug you are going to continuously keep increasing and what kind of a route you are going to give the drug into the body. That is going to decide whether the person is going to be in the minimal sedation or scaling up to moderate sedation or deep sedation or slipping into general anesthesia. But as far as when you talk about conscious sedation, we are only going to talk about minimal sedation and moderate sedation. Trust me, nitrous oxide is incapable of putting somebody to deep sedation general anesthesia. We'll talk about it later. That is the reason why we stick to nitrous oxide without any additional drug added to it. So nitrous oxide is incapable of putting somebody to deep sedation and general anesthesia. So at whatever dose you give nitrous oxide at, it is going to be maintaining the person either in the minimal sedative level or a moderate sedative level without pushing them to any further. So that is the safest assurance you are going to get from nitrous oxide. As long as the person is in the state of conscious sedation, the person is going to be responsive when it comes to verbal commands. The airway of the person is independently maintained. The ventilation is going to be spontaneous without any help, and cardiovascular function will remain uninterrupted. That is what you are going to expect in this window of minimal and moderate sedation. The things are going to be different in deep sedation, and he needs little intervention. The ventilation is not going to be adequate. And when it goes to general anesthesia, whole ball game is going to be different. So the scope of today's talk is entirely to do with minimal sedation and moderate sedation with nitrous oxide inhalation sedation. And American Association of Pediatric Dentistry has subclassified the sedation to 5 functional levels. 1 is going to be anxiolysis. Number 2 is going to be interactive. 3 is going to be non-interactive arousal with moderate stimuli. And 4 is going to be non-interactive arousal with intense stimuli. And 5 is general anesthesia. You can appreciate the color change in these terms. As long as we are in the greener shades, we are in the safer situations. And as you go down and you are going to be into little more physiologically uncontrollable situations where you need little beyond, you need skills little beyond a dentist. So in anesthetist is a better person to handle a person when you are going to be put into AAPD sedation levels of 4 and 5s. But with the nitrous oxide inhalation sedation, you're going to have a person sticking onto anxiolysis, and he will continue to be interactive verbally. As long as you talk, he's going to respond back either by voice or by gesture, but he's going to be responding back to you in a meaningful way. There could be a situation where sometimes, rarely, nitrous oxide may put somebody to non-interactive, but if you simply call them by name, they're going to be aroused. That means if you look at a person when they're sedated, if I'm going to be like this, if you see my eyes, I'm half closed my eyes, which may tell you that I'm little sedated. And at some point of time, I'm not responding. If somebody calls me by name, Srinivas, I'm not getting up. And if somebody, Srinivas, wake up. So I'm not interactive, but I was aroused with mild and moderate stimuli. So this is the maximum limit you are going to achieve with nitrous oxide inhalation sedation. So nitrous oxide inhalation sedation is going to restrain the person from anxiolytic stage, interactive stage, and non-interactive with arousal moderate stimuli. And this is the window in which we are going to use nitrous oxide, and this is the scope of nitrous oxide we are going to learn about. And as part of our pharmacological training, we have many routes being taught to us: intramuscular routes and submucosal, oral, rectal, transmucosal, intravenous, and inhalational routes. But when it comes to dentistry, when it comes to sedations, we only use 3 forms of 3 routes, that is either oral route or inhalational route or intravenous route. These are the 3 most commonly used routes to administer a sedative into the body. Now, when it comes to the fastest way, it is the IV sedation, because it takes about fraction of a second for the drug to get into the blood, and the drug is going to be taken to the area where you have the blood-brain barrier, and when the drug crosses the blood-brain barrier, it gets into the central nervous system, and it starts showing the effect. So from the time it is injected till the time it reaches the central nervous system, it takes probably about few seconds. So that is the speed at which the sedative is going to be acting when you introduce the drug intravenously. But when we talk about the easiest method is always an oral route, where you simply give a drug in a small cup or small spoon. The child is going to swish it in, and we are going to wait for about 10 to 15 minutes time. and the child or an adult will start, child will start getting sedative effects, then he will be put into minimal and moderate sedation depending on what drug and how much dosage are we going to give. But the point is, it is the easiest form of administering a sedative drug into the body, but the fastest is the IV sedative drug. Now we need to strike something in between, that is inhalational route. The inhalational route is considered one of the safest ways to administer drug into the body, where it will have little speed from IV sedative, speed compared to IV sedation, and it is simpler and easy, not as simple as oral sedation, but it is little easier than IV sedations. So when it comes to safest method, inhalational route is considered one of the safest ways to administer the drug into the body. That is what we are going to learn, and we are going to learn why is it considered safe to give a drug in an inhalational route. Now next comes to why do we use nitrous oxide, not any other anesthetic gases. Now to know about it, we need to know a little more about something called margin of safety. The margin of safety is that the drug and the techniques used to provide the conscious sedation in the dental treatment should carry a margin of safety so wide enough that even unintentionally also, you will not render the person unconscious. Let me repeat this once again. The margin of safety means when you give a drug, or when you give a drug with such a route, the margin of safety or the safety of that drug should be so wide enough that even unintentionally also you should not make the person unconscious. Hope you understood this good enough. So nitrous oxide is considered having one of the widest safety of margins, and that is considered as, and for that reason, nitrous oxide is considered one of the safest sedative drug used in dentistry. And that's the reason why nitrous oxide is so popular across countries as far as use of sedative to deliver dental practice. Nitrous oxide was discovered by somebody called Horace Wells in 1840. So it's almost probably about almost 2 centuries old drug. And Joseph Priestley also discovered oxygen, and people like Horace Wells gave nitrous oxide a little more exposure when he started using the nitrous oxide for the dental treatment. In fact, he started using it as an anesthetic drug. And for that reason, Horace Wells is considered the father of anesthesiology by anesthesiologists. And Harry Langa is one of the people who gave a structural instruction to be taught in US dental schools about nitrous oxide inhalation sedation. Nitrous oxide to learn about is an inexpensive inorganic gas. It's a colorless, sweet smelling gas. It's a non-inflammable but supports combustion. It doesn't produce flame, but it makes a flame bigger flame. If there's a flame, it makes the flame bigger flame. It's non-irritant to the mucosa because nitrous oxide is inhaled. So any inhaled drug should not be irritant to the mucosa. So nitrous oxide doesn't irritate the nasal mucosa, so that you're not going to have any adverse reactions with the nitrous oxide. Nitrous oxide do not react with any other anesthetics. For that matter, nitrous oxide do not react with any other drug for that matter. It may have only cumulative effect when you use it with any other additional sedative agent, but it does not have the cross reactivity like many other drugs we see in dentistry. Nitrous oxide is not metabolized in the body because it doesn't react with any cell in the body. Cells make an organ in the body. Since nitrous oxide do not have any reactivity with any cell, it is not going to have any reactivity with any organ system. That means virtually nitrous oxide do not react with any organ in the body. This is supposed to be one of the greatest advantages of nitrous oxide, meaning any person with any kind of illnesses, or rather most of the illnesses, are going to be indications for nitrous oxide, and we are not going to be worried about any kind of systemic illnesses except for very few. We are going to talk about it a little later. Advantages of nitrous oxide, that it has something called anxiolysis. Anxiolysis is one of the primary outcome of nitrous oxide. That means a person who inhales nitrous oxide will start feeling relieved from fear. He is going to be free of anxiety. He is going to be more relaxed. He is going to be smiling at you. He is going to be listening to you more attentively because he's not dictated by fear. Once to separate a person from fear, he is going to be more comfortable to receive your treatment. He is going to be more comfortable to receive your instructions. He is going to be listening to you properly. He is going to be paying more attention to you. So you're going to have so many advantages because of anxiolytic effect of nitrous oxide. Once you start giving nitrous oxide, the person is going to be very, very relaxed, and that is where his cooperation is going to be being realized. And nitrous oxide also gives a little bit of analgesia, not to a potential effect where you can extract a tooth without local anesthesia, but it does give you little resistance to local anesthetic injections. That's the reason why you can use nitrous oxide. With the nitrous oxide, you can deliver the local anesthesia without pain. That's what I was mentioning in the beginning, that we can give local anesthesia without pain, where we never gave this option before. And the person also can have a little amnesia. That means as long as the person is experiencing effects of nitrous oxide, he may not memorize the happenings, even if it is a painful experience. He may not remember the painful experience once the nitrous oxide leaves the body or the person is out of a sedative effect. So that's called amnesia. This may not be as potent as anxiolysis, but you can still realize a little bit of little bit of analgesia and a little bit of amnesia. Does nitrous oxide produce anesthesia? Though we have learned about nitrous oxide that it is an anesthetic gas, it is a very, very weak anesthetic gas. And in anesthesiology, nitrous oxide is basically used as a carrier gas, not as a primary anesthetic agent. There are other potential gases like sevoflurane, isoflurane, which are going to be used with their more potential to give anesthetic effects rather than nitrous oxide. But nitrous oxide is still being used as a carrier gas. That means by using nitrous oxide along with sevoflurane, you can reduce the amount of sevoflurane so that the end expenditure can be reduced to the patient. Hallmark safety features of nitrous oxide is that it has that rapid inductive power where you can achieve nitrous oxide's sedative effect starting from 0 time, and within about 3 to 5 minutes, you can have a person who is very relaxed. It takes about 3 to 5 minutes. This may not be as fast as IV sedative agent, but it may take about 3 to 5 minutes, which is reasonable enough. For the dental treatment. We don't want sedative effect to start like that, but we have enough time to realize that. And we also have recovery from nitrous oxide within 3 to 5 minutes when you cut down nitrous oxide. And the person is going to be back in his senses in about 3 to 5 minutes, where the person can be sent home, discharged in a physiological state of safe discharge. The person is going to be going home unaccompanied if he's an adult. That's the advantage of nitrous oxide. Now we'll also learn how is this possible? What makes this nitrous oxide so safe is what we are going to learn in further slides. We are going to learn a little bit of pulmonary anatomy, physiology, and pharmacokinetics of nitrous oxide so that we'll have a little more understanding about how exactly nitrous oxide works. We all aware that respiratory system is compared to an inverted tree, where you see the pharynx, the nasopharynx, and all the other things compared to a trunk of the tree, and the terminal parts of the lung are compared to the leaves. Yeah. So this is how the air, when you inhale, is going to be through the nose or through the mouth. It's going to be through your oropharynx, nasopharynx, oropharynx, and larynx. It will go to trachea and tracheoles and into the alveoli. Alveoli are considered the end organ of the lungs, where the gaseous exchange is going to happen. When it comes to, this is how the alveoli are going to be. They look like grapes, and alveolar the terminal alveolar organ is going to be looking like something like this. If you see this place here, you can see the alveolar cavity lined with the cells. At some point of places, you also have these blood vessels, and these blood vessels, which are around the area where the air is going to be, there is going to be gaseous exchange. The gaseous exchange is going to be somewhere here. Yeah, this is the alveolar cavity, and this is the blood vessel. And whenever there is going to be a gas on one side, based on the partial pressure difference, that means if the partial pressure of the gas on one side is more, for example, if the partial pressure of the oxygen is more on your alveolar side, that is going to be slowly go on to the other side through the alveolar membrane into the blood vessel. This is called alveolar exchange. And the permeability of the alveolar membrane is called alveolar permeability. So alveolar permeability will allow the gases flow from high partial pressure on the alveolar area to the lower partial pressure in the blood vessel. Similarly, when you put nitrous oxide here, when you inhale, the nitrous oxide's partial pressure is going to be more here, and the nitrous oxide's partial pressure is going to be less on the blood vessel side. There is going to be higher partial pressure on the alveolar side and lesser partial pressure on the blood side. So nitrous oxide is going to be diffusing through the alveolar membrane, and it will continue to get deposited in the blood circulation. That is how the nitrous oxide is going to be transferred from the alveoli here onto the blood circulation side. So once the nitrous oxide gets into the circulation, nitrous oxide is going to be taken by the circulation wherever the blood flows, and it is going to be even into the cerebral circulation, and it is going to cross blood-brain barrier, and it is going to reach certain receptors, and that is where the nitrous oxide is going to be effective in terms of reducing the consciousness of the patient. I don't want to confuse people by explaining the mechanism of action of nitrous oxide, because that is little irrelevant at this point of time. But what you need to know is that the nitrous oxide crosses the blood-brain barrier. It works on certain receptors like barbiturates, and it reduces the consciousness of the patient. Yeah, that is how nitrous oxide is going to be working. This is about how nitrous oxide's mechanism when it comes to sedative effect is considered. To recapitulate, nitrous oxide, when you inhale through the nose, it will go to the pharynx, it will go to the trachea, and it will get into the alveolar cavity. From the alveolar cavity, it is going to be transferred onto the blood vessels through alveolar membrane, which is called as alveolar permeability, and that's how the effect of nitrous oxide is going to be realized on the cerebral nervous system, central nervous system. Yeah, and next we'll jump on to the nitrous oxide and its effects on systemic organs. Please recollect what we have discussed a few slides ago, that nitrous oxide do not react with any cells. It is the cells which makes the organ. That means nitrous oxide do not have any major effects on any organ system, such as central nervous system, except for reduction of the consciousness. Nitrous oxide do not have any other effect on the central nervous system. Or it could be Alzheimer's in adults, it could be autism in children, it could be Parkinson's in adults, or it could be any other central nervous systems disorders. Nitrous oxide, except for reduction in the consciousness, it is not going to have any effect on neurons or neuronal connectivity. So that's how the nitrous oxide do not have any effects on cerebral tissues. Number two, nitrous oxide is not expected to have any effect on cardiovascular circulation, except that it is going to be resulting in little bit of vascular dilation in the peripheral vessels, and it reduces little. It will have a minimal reduction in the pumping capacity of the heart. Other than that, it does not have any effect on any cardiovascular systems. Nitrous oxide is not metabolized in liver, so it is not going to be of any danger to the hepatic cells or hepatobiliary system. Nitrous oxide is safe for people who suffer from any liver disorders. Nitrous oxide is safe for people who suffer from any kind of cardiac illnesses. Nitrous oxide is not going to be metabolized in the gastrointestinal tract. So it is going to be safe for people who suffer from any kind of gastrointestinal elements. And nitrous oxide is not going to be eliminated by kidneys. The nitrous oxide is not going to be altering the filtration capacity of the nephrons. Nitrous oxide is not going to be affecting the elimination of the urine. So even if a person suffers from any kind of renal elements, nitrous oxide is safe to be used on them. Nitrous oxide is also not going to be affecting the blood and hematopoietic system. Yes, nitrous oxide is known to have bone marrow suppression, but not by one-time usage on a patient, but it is going to have deleterious effects on the clinician if you don't follow certain hygiene rules, hygiene guidelines. So nitrous oxide is safe for the patient even when they suffer from any kind of blood-borne disorders, but nitrous oxide is not going to be safe for the clinician who is going to be exposing themselves on day-to-day life, and if they don't use proper scavenging systems, it is going to have a deleterious effects on the clinician. There are only two systems which are going to be affecting nitrous oxide and its effectivity on the human body. That is how you inhale the gas and take the gas from the outside environment to the alveoli, and how nitrous oxide is going to be exchanged at the alveolar membrane. So if at all you want to consider a patient for nitrous oxide sedation in dental practice, you only need to worry about number one, his respiratory tract patency and his alveolar permeability. Yeah. And we are going to talk about the behavioral issues a little later, but at this point of time, when it comes to systemic influences of nitrous oxide, almost all the elements of safe are safe for nitrous oxide. There are not going to be any contraindications for nitrous oxide unless there is an obstruction in the airway, like chronic obstructive pulmonary disease. So that's just one example of it. I'm sure all of you are aware of American Society of Anesthesiologists classification of physical status. This is one classification we all use day in and day out to have an understanding about the physical status of the patient. ASA classification will have a lot of relevance in patients who are going to be posted or scheduled for any kind of procedure under general anesthesia. But symbolically, dentists can also use ASA classification to have an awareness of what is the physical status of the person who is going to be treated under nitrous oxide for the dental elements. So when a person is classified under ASA classification 1, who is normal and healthy patient, he is absolute indicated patient for nitrous oxide. A patient who is classified in ASA 2, a patient with mild systemic disease, can still be taken without any hindrance with nitrous oxide. ASA patient 3, a patient who has severe systemic disease, also can be treated with nitrous oxide, but little more caution need to be used. They are best treated in a hospital situation rather than standalone dental clinics. As far as the ASA 1 and the ASA 2, we can happily treat them in standalone dental clinics. Incidentally, for our dental practices, 95% of the patients whoever walks into practices, either ASA 1s or ASA 2s, when it comes to handicapping conditions or special needs patients, probably they'll be put in ASA 3. Such patients are best treated under nitrous oxide in a hospital-based situation. But majority of the patients can be treated in normal standalone ambulatory dental practices who are either classified either ASA 1 or ASA 2s. Next, we'll jump on to little idea. Let's have a little idea about the machinery and the parts of the machine. Detailed explanation of the machine is beyond the scope of this talk because we have about 1 hour's time. I don't think it is fair to squeeze in every part of this topic into one lecture. So briefly, we need to know about different parts of the machine. This is the whole machine. This is the mirror image where there is a mirror behind it. There are few parts on the machine. This is called the head. This part is called the yoke, and these are called conduction tubings. And this tube here, this white tube here, is called a delivery tubings, and these are called nasal hoods. When you use nitrous oxide on a patient, the patient is expected to have this hood on the nose. Patient expected to have this hood on the nose, and he's going to keep the mouth open so that we can deliver the treatment in the mouth. We don't want to share the airway with the nitrous oxide's delivery system, so we make the patient inhale through the nose when you keep the mouth open. This is in fact
alert from system is over.
Sorry. This is in fact one of the major disadvantages of nitrous oxide, because whenever we consider using nitrous oxide, we expect a child or the patient or the person who has any special needs to understand this information, that he has to have this nasal hood on the nose and he has to keep the mouth open and breathe through the mouth. Sorry, breathe through the nose. I repeat this. The disadvantage of nitrous oxide, this is a very important disadvantage with nitrous oxide, very typical to nitrous oxide. When you use nitrous oxide to deliver sedative while you're working for delivering the dental treatment, the person is expected to have the nasal hood on the nose and inhale the gases through the nose and keep the mouth open so that you can deliver the treatment in the mouth. This is a little tricky situation. Not many children be able to understand this instruction. They will by mistake continues to breathe through the mouth. So they don't actually inhale nitrous oxide. They are going to inhale room air. That is the big disadvantage with nitrous oxide. In fact, this is the only disadvantage of nitrous oxide with all the advantage on its side. So anybody who has intellectually disabled, that means if the person has any kind of mental retardation or any kind of behavioral issues or any kind of learning disabilities, you may not be able to comfortably explain this child that they have to keep the nose hood on the nose and keep the mouth open, breathe through the nose and keep the mouth open for deliver the treatment. This is the tricky part of the. So any child or any adult or any special needs person who cannot understand this instruction are absolutely contraindicated for nitrous oxide. That's a big disadvantage and big put off from nitrous oxide. Other than this, we have all advantages with nitrous oxide. And we do have different sizes of nasal hoods here. We have nasal hoods here. We have large, we have medium, and we have small. Depending on the size of the nose and size of the face, we are going to choose one of these three nasal hoods so that it fits onto the nose without much of leak around it. This leak should not happen from the rim of it when it is on the skin side. Okay, we'll discuss about this little later. These are different kinds of machines. I think it's little irrelevant for us to know about it at this point of time. Let's skip this. Let's skip this. For your information, though we have learned about a sedation machine, we simply saw an image of it. But what you need to understand is, if you have to call a sedation machine a dental sedation machine, it should have specific safety mechanisms. So these safety mechanisms are very ideal and very specific to dental sedation machines. And almost all the sedation machines which has some kind of a standard are expected to have at least of these 12 safety features built into them. Number one, like pin index safety system. I don't want to go into the details of it. I will probably send a video. I was explaining this to Dr. Gichu that I will send another video about the parts of the machine with the proper explanation and how exactly you're going to operate the machine and all those things. But these are the safety features which you need to know about when you are buying a machine. Yeah. When it comes to the technique, I'll quickly run across the technique because I wanted to show you a video. I have a problem with my video. I am not able to use the video. I'm going to share that video a little later. And I'm sure Dr. Gichu is going to share it across from the forum of Kenyan Pediatric Dentistry Association. And when you look at the head here, we have two parts here. We have a mixture valve here, and we have a flow meter valve. These are the only two valves which you need to handle when you have to handle the machine. And this is something called oxygen flush. Don't bother about all these things. The idea of that adjustments, number one is, let us learn number one about the first control, that is this part. This is called flow meter. Flow meter is going to give you that kind of mixture of gases of nitrous oxide and oxygen to the machine, and you measure that in number of liters. And we have another control here, which is called mixture, which is going to be used to adjust nitrous oxide and oxygen in proportion. Ideally, nitrous oxide and oxygen here on these tubes which are represented, this represents nitrous oxide and this tube represents oxygen. They are inversely proportionate to each other. That means if oxygen is going up here, the nitrous oxide comes down. If nitrous oxide goes down here, oxygen goes up here. That means when you are increasing, when you're decreasing oxygen here, nitrous oxide is going to be increasing. I will explain that in the video when we come across. But you need to know different steps in treatment planning when you use nitrous oxide. First, we have to understand the need of the use of sedation. That means it all depends on what kind of apprehension the child has, what kind of a relaxation you are looking at. Every patient will come to your treatment, and when they receive the dental treatment, every dental treatment will come with certain amount of discomfort packaged with it. For example, I may get my scaling done without any apprehension, but somebody else may not even let you touch the scale to the tooth. They will just jump out of that. So people will have different levels of apprehensions in them. Depending on their apprehension, you need to have that much of resistance from the patient in terms of consciousness. You want that much of unconsciousness of the patient so that he will resist that much of fear. So based on that, you are going to give an increasing amount of nitrous oxide to the patient so that you will achieve certain amount of relaxation in the patient. We'll talk about it a little later. For that, you also need to know a little behavior assessment. I will not touch about behavioral assessment at this point of time. But what is most important thing is that we need to counsel the parent and the child about how exactly nitrous oxide is going to be used and how exactly the person is expected to breathe through the nose when he keeps the mouth open, and what is expected from nitrous oxide sedation. And we need to also give some kind of an overview about how exactly the whole procedure is going to be going on to the parents, so that they will not start asking questions in between, so that your whole attention is going to be on the child and the treatment. So counseling the parent and the child a day before probably, or 1 or 2 hours prior to the procedure, is going to be a great attempt, so that you reduce the apprehensions and you make the person understand and realize the sedative effect more appropriately. We also need to know about medical history of the patient. As I said, even medical history says that you can use nitrous oxide, but you are going to deliver the dental treatment. That medical history could be relevant for the dental treatment, not necessarily for nitrous oxide. Nitrous oxide will have a very fewer contraindications, but your dental treatment may be relevant to many medical conditions in the patient. So it's very important that you know about the medical conditions. And we also need to know about the drug history. And here, when a person is going to be using any kind of a sedative drug, you need to be a little more careful with nitrous oxide, because the person already came with sedative effect. With the nitrous oxide is going to be much more sedated, even with the lower doses of nitrous oxide. So it's very important that to know that whether if the person is under influence of any sedative drug. When it comes to the children, one of the most common sedative drug the child might come to your practices with is that the antihistamines. Most of the antihistamines, including the cetirizine, can result in a little bit of drowsiness. So with the cetirizine in the body, if you start using nitrous oxide, the person will start getting sedative effect at a much lower doses of nitrous oxide, where you will miss the actual realization of sedative effects, which is going to be comfortable. We also need to make the respiratory diagnosis as so as to whether the person can inhale. You can look at the respiration, whether the person is comfortably respiring, inhaling out or inhaling down. You need to ask whether the person suffers from any kind of blocked nose, whether the person has any kind of chronic obstructive pulmonary disease. Does the person has any kind of a deviated nasal septum, which is not going to allow the person to inhale the nitrous oxide or any gases for that matter through the nasal hood. These people are going to be a relative contraindication or probably contraindication for nitrous oxides usage. We also need to know about a little detail about the alveolar condition such as cystic fibrosis or tuberculosis. All those things will result in fibrosis of alveolar membrane, which is not going to allow the gases to transfer from alveolus to the blood circulation. So when the gases don't transfer, that means either nitrous oxide also don't get onto the other side, and you're not going to release appropriate sedative effect of nitrous oxide. And the next part of the technique is we need to clear the nose. I always ask my children or adults to clear the nose. I will ask them to use the restroom, relieve the bladder first, because you don't want children to start telling you that they wanted to use the restroom in between the treatment. Even without sedation, that's my advice to most of the parents, that take the children to the restroom, let them relieve the bladder, let them come back with little ease. And at the same time, we'll ask them to clean the noses. When we look into the noses, many children, we see the crust of nasal discharge will be so thick in the nose that the child is actually breathing through the nose. So once you clean the nose, once you ask the patient to clean the nose and remove the discharges and remove all those dried nasal discharges, the child is going to be much more comfortable. So this is going to be a practice for any dentist, especially pediatric dentists, before they start doing any dental procedures, even without sedation. Clean the nose and ask them to relieve the bladders. So these are the two instructions by default will go for all the patients. And this is going to be much more relevant if you're going to use nitrous oxide, because your respiration of nitrous oxide is going to be through the nose. And we need to choose the appropriate nasal hood. It's not a rocket science. You simply have to put the nasal hood on the nose and see if there is any gaps around it. So you only have three choices. Most of the times, these three nasal hoods of sizes large, small, medium, and small will fit snugly on the nasal hood without any leakage. If there is any leakage, the person is going to be actually inhaling the room air without nitrous oxide. When you expect them to be highly sedated, they will not be sedated. So in the midst of the nitrous oxide sedation procedures, even when you're using nitrous oxide at a higher dose, the patient says that he's not feeling any sedative effect, first thing you need to suspect is there could be some kind of a leak around the nose where he's going to inhale the room air into it. So that's something which you need to be aware of. Once you do that, put the pulse oximeter on the finger. I'm sure everybody is aware of pulse oximeter now. The pulse oximeter is basically to know the saturation of the oxygen in the body. It should be showing anywhere between 95 and 100 when you put it onto the finger, which is going to be showing the appropriate oxygenation capacity of the blood and the hemoglobin. And once you do that, and you know that the person is appropriately saturated. And we also need to record basic vital statistics such as pulse rate, respiratory rate, and saturation, which we are going to discuss a little later. And step three, we are going to place the nasal hood on the nose, fix the flow rate, and we need to increase and decrease the nitrous oxide based on the apprehension of the patient. And the more apprehensive the patient is going to be, you keep increasing nitrous oxide to such a level where the person is going to be more relaxed. How do you know whether the person is relaxed? It's not a rocket science for us to know whether the person is relaxed. When the person is not relaxed, if he's afraid of something, you can actually look into his face and you know that the person is apprehensive. With the effect of sedation from the nitrous oxide, you can see a smile on his face. His muscles are relaxed. His hands are relaxed. He is going to be much more easily communicative with you. Everything is going to give you an idea of how is his mood is going to be, how is he going to be relaxed, and you will very well realize how much sedated it is going to be. I will talk about the monitoring in the next 2-3 slides. And rubber dam usage is going to be a good tool when you use nitrous oxide, because when you use rubber dam in the mouth, the rubber dam is going to close the lips. So you don't have to give instruction to the patient to breathe through the nose, because there is not going to be any access to the breathing through the mouth. He is forced to breathe through the nose. For that, the nose need to be patent. But if nose is patent, if you use rubber dam, the person can comfortably breathe through the nose, and you can realize the effects of nitrous oxide much more effectively. So meaning use of rubber dam is going to be of invaluable support with the nitrous oxide. So rubber dam and nitrous oxide are inseparable tools in your practice. Yeah. Then once you achieve that appropriate level of sedation, you can start delivering the treatment. And I'm talking about monitoring a little later. And once you finish the procedure, as I said, nitrous oxide has got great speed of recovery. Moment you cut down nitrous oxide, the whole nitrous oxide in the body is going to come out of the body in about 3 to 5 minutes time. Whereas when you give a drug through the IV route or oral route, the drug is going to take much longer time. Depending on the route and the dosage of the drug, it may take half an hour, 45 minutes, sometimes 2-3 hours for the drug to come out of the body. But when it comes to nitrous oxide through inhalational route, it will never take more than 3 to 5 minutes for nitrous oxide to come out. Meaning, after you finish your treatment, after you cut your nitrous oxide off, the nitrous oxide is going to come out of the body entirely in about 3 to 5 minutes time. Then the person is actually fit to be discharged out of your clinic unaccompanied. The person can walk out of your practice without any help, unlike any other form of sedation or route of sedation. That is the greatest advantage of nitrous oxide when it is used in dental practice. Many people would have a doubt that what is the appropriate amount of nitrous oxide we may have to give to achieve that kind of a comfort zone, what we are talking about. Most of the people, about 60 to 80% of the people, will be absolutely comfortable when you give nitrous oxides concentration at about 30 and 40. When you give nitrous oxides percentage between 30 and 40, you can expect the person to be absolutely relaxed. He's going to be happily sitting on your tooth, and he's going to have enough anxiolysis. He will have enough analgesia so that you can give local anesthesia, and he's going to be relaxed. He's going to be more cooperative, and all that is achieved when you give nitrous oxide anywhere between 30 and 40% of nitrous oxide. But some children or some adults may need something more than 70% of, more than 50% of nitrous oxide. Some children and some adults may require even less than 30%. Even at 20%, some children, some adults may have appropriate level of sedation. But the majority of them will require anywhere between 30 and 40% of nitrous oxide. Next, we'll come across, though nitrous oxide is considered one of the safest drugs to be used to deliver the sedative effects into the body for delivery of dental treatment, it poses certain risks to the clinician. What are those risks? And the risks depend on how much of nitrous oxide as a clinician I inhale, and for how many hours will I inhale is what is going to determine my ill effects suffering from nitrous oxide. The maximum recommended dosage of nitrous oxide is about 100 ppm of nitrous oxide, which is inhaled over 8 hours of exposure. That means if you continuously work on people and children for hours together, say for example 5 to 8 hours every day, and if you're using high amounts of nitrous oxide, that is little beyond 50% or 60% or even 70% of nitrous oxide, the occupational hazards can kick in. Okay, so to limit the occupational hazards, you should not be using higher amount of nitrous oxides, and you should not be using nitrous oxide for long hours of the procedures. We also need to be aware that when you expect the response to the response by the patient to verbal commands, let those responses be gestural. That means if you ask a child, how is he is expected to tell you, I'm fine this way, thumbs up. But he's not expected to vocalize his answer. If you ask him, how is he? He's not expected to say, I'm fine. When he says, I'm fine, he is going to expel out all the nitrous oxide out of the lungs, and he is not going to have appropriate sedation, and he's also going to contribute for room air. So do not expect the patient to be talking while you give nitrous oxide, unlike any other sedative form, but you need to expect the person to be gesturally responding to your verbal commands. For example, you ask him, how many friends do you have? You should be able to tell 2 friends. How many siblings do you have? Probably you'll say 2. Show your right thumb. That's how he's going to show. That's how you are expecting him to respond to your gestural responses. Once you cross this limit of occupational hazards, the risks which are encountered are miscarriages in females, bone marrow suppressions. If I suffer from any kind of a bone marrow suppression, if I am a trainer in nitrous oxide, and if I also practice nitrous oxide in my practice, I am going to inhale a lot of nitrous oxide. My already burdened bone marrow is going to be burdened more because of continuous exposure of nitrous oxide. So as a clinician, if you have any factors which are going to be compromising your bone marrow, be very careful when you use nitrous oxide. Only thing you need to keep monitoring your cellular counts by complete blood picture or a hemogram, and you need to look at vitamin B12 activity so that you will not come across any kind of neuronal ill effects of nitrous oxide. There could be possibility of abuse by the dentist and the nursing staff because of euphoric effects of nitrous oxide. So be careful in your practices. Keep the nitrous oxide under lock and key so that there is not going to be any abuse. People who abuse nitrous oxide will come across these occupational hazards, whatever we have talked about. Be careful that nitrous oxide is not being abused or misused in our practices. Nitrous oxide, though not proven to result in birth defects, it is best avoided during first trimesters of pregnancy so that nitrous oxide cannot be inadvertently implicated with whatever birth defects the child is born with. Like any other drug, nitrous oxide is best avoided during the first trimester of pregnancy. To avoid occupational hazards, one, how do you stick to the limits? Number one, you should be using well-ventilated room. The room should be very well air-conditioned with about 15 cycles of air circulation. That means the room air need to be ventilated properly. Fans need to be switched on so that you waft away the gases, so that you don't inhale the gas, because you are going to be right next to the mouth when the person is exhaling the nitrous oxide. So there should be some kind of a fan on top of it, and the fan need to be wafting away the gases which are going to be excreted around. The best way to escape from occupational hazards is to use a scavenging outlet. That means you use a scavenging outlet connected to a vacuum source. The vacuum source is going to suck the nitrous oxide which is going to be exhaled, and the nitrous oxide which is going to be sucked, which is going to be released away from the operatory. There are many clinicians who simply leave the tube outside the window, which has got no relevance here, because nitrous oxide is not water to flow out. Nitrous oxide need to be sucked. That means it has to be connected to a vacuum source. The vacuum source will remove the nitrous oxide from the room, and it is going to be released outside your operatory so that you can't come across the occupational hazards. So this is something which you need to keep in mind. You need to have a good exhaust system. The exhaust system for nitrous oxide should not be on the top, because most of the exhaust system will be on the roof. Because nitrous oxide is heavier than the room air, the nitrous oxide is going to be floating on the floor. That means if at all you want to have an exhaust system, it should be on the floor so that it doesn't let you inhale nitrous oxide because you are at the floor level. Most of the exhaust system in our practices are at the roof. For purpose of nitrous oxide, it should be at the floor because nitrous oxide is heavier than room air. Should we have a dedicated operatory? As long as we have a good ventilation to remove all exhaled nitrous oxide, it is best not to use in a closed room without any ventilation. If you have a good ventilation and good vacuum system to evacuate nitrous oxide, then you can have a dedicated operatory for nitrous oxide inhalation system. Now, finally, we're going to come out for monitoring. There are only 3 parameters to monitor in nitrous oxide. One is consciousness, number 2, respiration, number 3, saturation. The first form of saturation, first form of consciousness, we already know, we already understand, because the person is expected to respond. Person is expected to respond gesturally. That means the person need to be conscious enough to respond. That means as long as the person is responding to your verbal commands, that means his respiratory system and saturation are working well. So as long as the person is responding well, you have no issue of monitoring respiratory system and saturation. But the moment the person is compromised on responding to your verbal commands, then you should start looking at respiration and saturation. Consciousness, as I said, you need to look at the response to verbal commands. You need to look at the movements of the eyes, like the blink rate and our movements of the eyes. For example, if you look at my eyes, under influence of nitrous oxide, without influence of nitrous oxide, I may blink my eyes like this. But under influence of nitrous oxide, I may have my eyes closed like this. My blink rate is going to be very slow like this. I'm not going to be blink like this. My blink rate is going to be very slow like this. Yeah, that is going to tell you a level of consciousness. The way person move eye left to right also will tell you, depending on how alertly they move. As the person go up on the level of sedation, the movements of the eyes will be very slurred and slow. Ability to keep the mouth open, slow down the movements, slurred speech are all going to be indicative of the level of consciousness. But keep that in mind, response to verbal commands, movements of the eyes, blink rate are the 3 most important expressions of your consciousness. Respiration is expressed by something called reservoir bag. I think I missed explaining about reservoir bag. There was a black bag which was shown on the machine. The black bag, as you inhale and exhale, the bag is going to inhale and exhale like this, and that is going to clearly explain whether the person is respiring or not. So that is quite self-explanatory when you have a proper machine and if the bag is moving, and that monitoring is also taken care of. The third parameter is called saturation. Luckily, we have the mucosa around the teeth, which is going to be very expressive about the saturation of the body. And moment the person starts becoming pale, their lips becoming pale, you know that the saturation is dropping. That means the oxygen carrying capacity of the cells is dropping down. That should tell you that you need to suspect about the respiration and of any kind of obstruction in the airway. So that will alert you. So to make you a little more reassured, there is a tool which is called pulse oximeter. We are all aware of pulse oximeter, which is available nowadays in all our practices. And pulse oximeter will realistically explain about saturatory status of the person. When it comes to how frequently you should monitor at least once in 3 minutes about consciousness, respiration, saturation. You don't have to keep looking at the patient, but as long as the person is responding gesturally about consciousness, that means if you know that the person is saying yes or no or showing the fingers in a way how you expect him to respond, the consciousness is very well maintained. And this need to be done once in 3 minutes. The question sometimes, can you as a dentist, can you deliver the nitrous oxide sedation alone, or should you have an assistant for you? Nitrous oxide sedation is the only form of sedation a dentist will be appropriate person to deliver, and as well as consider doing the treatment also without any additional help. But it is a good practice to have an additional person to operate the machine so that your attention is more on the treatment rather than monitoring of the patient. So ideally, you should have a sedationist who need not be an anesthetist. You could have your child side assistant who's going to be monitoring all these parameters, and you can put all your attention on dental treatment without much of disturbance. Do we need an anesthetist? This is one of the common questions which we've been asked, at least in our country, many people ask whether you need an anesthetist. That depends on how prepared are we. That depends on how prepared are we in terms of training to deliver nitrous oxide. What kind of capability do we have about monitoring of the parameters such as saturation, respiratory monitoring, and consciousness? And what kind of emergency management skills we have? We are going to talk about emergency management skills a little later and briefly. And how far away do you have emergency medical care available to you? So all this is going to tell you whether you need an anesthetist. If you have all this with you, that you don't need an anesthetist. Sorry, you don't need an anesthetist for it. That means you should have a proper training about the machine. You should have a proper training about monitoring parameters. You should have appropriate training in the emergency management techniques. Now, when to do and when not to do of nitrous oxide, do's and or indications and contraindications of nitrous oxide. When to do, that is indications: mild to moderate dental anxiety. There is one misconception among dentists that extremely anxious children, should they be treated under nitrous oxide or not? Extremely anxious children will not be able to receive your instruction when you ask them to breathe through the nose. So they will not be able to inhale through the nose. That will not make them have respiration through the nose. They will start breathing through the mouth. That will never allow them to have the appropriate level of sedation. So children or adults with extreme anxiety will not be able to be a right candidates for nitrous oxide. So it is only the mild to moderate people, mild to moderate anxiety, people with mild to moderate anxiety who is going to be a right people for nitrous oxide. Anything more than that, that means if the person has severe anxiety, either you have to choose oral sedations or IV sedations to make them appropriately sedated. If you have a marked gag reflux, nitrous oxide is one of the best solutions because it reduces the reflux mechanisms because of the numbness which is going to be created around the pharynx. And it also makes the person comfortable when you actually start taking the impressions. So people who have a lot of gag sensations are going to be ideal candidates for nitrous oxide inhalation sedations. Traumatic, when you have to consider traumatic procedures in a cooperative patient, such as orthodontic extractions in a patient who does not have any other experience with pain, you can even consider doing extractions without any pain by using nitrous oxide in them. That means you can virtually do all the treatments wherever you expect little apprehension and fear without necessarily considering only when you have pain. Person who has phobia about needles, he is not worried about pain, but they are worried about needles. So these are the ideal candidates for nitrous oxide inhalation sedation. Children who requires multiple quadrant dentistry, they will, because of amnesia, they will lose that sense of time. The seemingly 15 minutes treatment actually took about 1.5 hours. Seemingly, for example, if you have to do a flap surgery or probably a root canal treatment, which may take about 45 minutes to 1 hour, the patient may feel that it must have happened in about 15 to 20 minutes time. They lose that sense of time. So where you can do multiple treatments in a quadrant dentistry without person realizing that they have sat there for a long periods of the time. There are certain adverse reactions with the nitrous oxide, which are very, very rare, very rare. They don't come across, we don't come across these adverse reactions in day-to-day practice. Only adverse reaction which happens in most of the times in a dental practice is vomiting and nausea. Other than that, rest of the reactions which you see here are very rare, very rare. The most common adverse reaction in nitrous oxide inhalation sedation, going by experiences of the clinicians or from the literature, is only the nausea and vomiting. Emergency training, there are many emergency training. I don't know about your country. There are trainings available for basic life support, pediatric advanced life support, advanced cardiac life support, or neonatal resuscitation program. Depending on the patient profile, you will choose appropriate emergency management skill. But the basic minimum is basic life support training, which is at least American Heart Association recognized. I'm sure you will have enough people to train you. Even without sedation, it's very important that we have exposure about basic life support training in our practices. Limitations of nitrous oxide. Limitations of nitrous oxide. We expect little bit of cooperation, which is essential. Language could be barrier. If I consider doing my nitrous oxide treatment in Kenya, probably I will not be able to explain somebody to breathe through the nose and keep the mouth open in Swahili. So language could be a barrier for nitrous oxide inhalation, which is very atypical form of contraindication. Extremely difficult or mentally handicapped patients may not be right candidates because one, they will not understand what you're talking about. Number two, because of the sedative drugs, what they'll be using. The restriction of the movement, especially when you're working in the anterior area, and this is going to be physical hindrance. The nasal hood is going to be on the nose, which will not allow you to visualize and give and working access to anterior area. This is a very atypical contraindication to nitrous oxide. Use of local anesthesia is still a must. If you think you can avoid local anesthesia by using nitrous oxide, no, local anesthesia still need to be used. Amnesia may or may not present all the time. You cannot simply think that the patient doesn't remember and do whatever painful procedures you want to do. You need to be a little considerate. Amnesia sometimes is not realized, so be very careful. Don't think that whatever you do which is painful will not be memorized by the patient. Then what is stopping us? What is stopping us? Number one, we don't have enough training as far as technique is concerned. We don't have any training as far as monitoring vitals is concerned. We don't have enough training as far as emergency management training. So when you have to have training, the training should include technique, monitoring vital parameters, and emergency management skills. Now, what kind of a training you should have? You will have introductory, proficiency, and the competency level. What we have gone through today is a lecture which is going to simply introduce nitrous oxide's concept to us. But if you really have to start working with nitrous oxide, you should have some kind of a proficiency level training or a competency level training. Proficiency level trainings will usually involve about 2 or 3 days hands-on workshops. Competency level is an in-house training where you will be training during a postgraduate or institutionalized training. What you need at least is a proficiency level of training. I'm sure, I don't know, Dr. Gichu was mentioning that they had got this training done in Israel last year. You need to get that kind of a training if you have to have that kind of a confidence with the nitrous oxide. By listening to a lecture like this, probably it will not give you enough confidence. You need to have a little more information and little more confidence about use of nitrous oxide. What else is stopping us? Expensive equipment. Equipment is expensive because in Indian currency, I don't know the conversion rates. Probably Dr. Gichu would give information about how expensive is the equipment. Cylinder, it involves equipment of nitrous oxide sedation unit. We need to have the cylinders. We need to have pulse oximeter. We need to have emergency management equipment. So all these things, among all these things, inhalation sedation machine is going to be most expensive, and the rest of them are not that expensive. But still, this is one of the hindrances for nitrous oxide's usage. This is one article which is going to be a baseline for all the guidelines across the countries. In fact, I was discussing with a few clinicians from Kenyan Association that you need to have some guidelines made for the dentist so that you will not have any mishaps happening because of nitrous oxides. Though nitrous oxide is very safe, any mishap will take the whole nitrous oxide back by a few decades. With great difficulty, a few clinicians in Nairobi are using it, but proper training and proper guidelines will safeguard the usage of nitrous oxide so that you get the best advantage of nitrous oxide in the practices. What is the scope on nitrous oxide? Sorry, what is the scope? There is a great demand. More and more children and adults are going to come into our practices asking for whether you have a gas. Many special needs children are going to be brought by the parents asking for use of sedatives, especially nitrous oxide, because of the safety. And definitely we are going to have such people walking into our practices. And it's important that we are braced for all those things by having your training. Nitrous oxide gives an additional comfort. It is an additional arsenal in our, it's an additional tool in our practice. It's a great practice builder. And I'm sure many patients will realize the comfortable feeling of nitrous oxide, and it's a great practice builder. And we have a different group of children walking into practices because of their access to internet and Google. They would have come across dental practices using nitrous oxide for the filling. They may come back and easily ask you, Doc, do you have gas or something? So you should be able to be prepared to answer all those requirements. So what else is the scope apart from use of nitrous oxide in dentistry? If you are practicing in a hospital, and you will have use of nitrous oxide and this machine in different branches, like in dermatology, podiatry, psychiatry, and many other clinicians can use the nitrous oxide and the machine when it is not being used by the dentist. I'm sure you will be able to introduce you to your hospital and make that also useful for other branches of medicine apart from dentistry. No doubt every branch of dentistry can use it, or every clinician in dentistry can use nitrous oxide effectively. And with this, we are coming to end of this talk. I'm sure I could not cater to a full understanding of about, because of the paucity of the time, because the limitation of the time, we may not be able to cover every aspect of it. But to recapitulate what we have learned till now, we have learned about need of sedation in dental practice. We have learned about few definitions about conscious sedation, and we have learned about why inhalation sedation and nitrous oxide are opted, considering its safety and other things. And we also need to look at the safety of nitrous oxide inhalation sedation in dentistry, and what kind of pulmonary physiology plays the role in absorbing nitrous oxide and showing its effectiveness. What kind of transfer of gases happening in the alveolar level? What kind of a machine and mechanism, which we could not do in detail? What kind of a patient preparation? And what kind of a monitoring, such as monitoring of consciousness, respiration, and saturation? What kind of emergency management skills we need to have? At least basic life support we need to have in our practices to give safety of to give a sense of safety to the patients. What are the limitations of nitrous oxide? What is the scope of nitrous oxide in our practices? And so on and so forth. And I'm very happy to associate myself with this great man called Maurice Clark. This book called Nitrous Oxide Inhalation Sedation is one of the greatest books available in dentistry for nitrous oxide. And I was glad to be associated with him for the training courses. And we also have another book by a renowned Indian author, Dr. Kunal Gupta. This is also one of the well-reviewed book as far as nitrous oxide inhalation sedation is concerned. I'm sure these two books will add a lot of value to your learning of nitrous oxide. With this, I thank each one of you for your patient listening. And in due course, I'm going to share a few videos, and I'm going to share it through Dr. Gichu. And Dr. Gichu is going to share it with the society, the association members. And thank you very much for your patient listening. And I'm ready to take any questions.
Thank you, Dr. Manish, for a wonderful presentation, for a wonderful journey to reach the sedation. And as rightly said, we need proper training to get over the fear, which we are lacking. So as time progresses and with your guidance, we'll have more training centers, and most of the centers will have the training facility, and I think we'll get over the fear. So it was a wonderful presentation, and thank you so much for all
Thank
your...
you, Doctor. Thank you, Dr. Manish.
I think we can start with the question and answer session.
Yeah. I will open the question answer sessions. What is the dose of nitrous oxide acts as laughing gas? Laughing gas, though nitrous oxide is called as laughing gas, laughing will not be appreciated, or it is not going to be happening in the day-to-day practice, because laughing will happen with a lot of euphoria. That lot of euphoria will happen at the higher doses of nitrous oxide. So when you see a person who is laughing because of nitrous oxide, you should realize and you should get alerted that you are actually reaching the higher doses of nitrous oxide. And laughing is only going to make the person expel all the nitrous oxide, and he is not going to let you work on the mouth. So laughing during the laughing gas usage in dentistry is undesirable. It happens only at higher doses of nitrous oxide. So when you see a person laughing, that means you should get down the nitrous oxide to your lower levels. Laughing, in control laughing will happen only after 60 or 70% of nitrous oxide. I think that how nitrous oxide causes bone marrow suppressions. Nitrous oxide basically will have an effect as far as hematopoiesis is concerned. Hematopoiesis is where the hematopoietic cells will start dividing into WBCs and RBCs and other things. So nitrous oxide will hinder the subclassification of the cells in the hematopoietic formation. Second to that, vitamin B12, which plays a major role in the hematopoietic system, is going to be obstructed because of nitrous oxide. These are the two reasons why nitrous oxide causes a bone marrow depression. Urinary bladder fullness, urge of urination while nitrous oxide, how to manage that? Usually that because nitrous oxide do not have any effect on elimination of the urine, he may not have any fullness because of the nitrous oxide, because he already has the bladder full. Because of the relaxation, he may relieve the bladder. The sphincters will release, and the person the children may urinate while procedure is being happened. So to get rid of it, it's good habit to make a person to relieve the bladder and come for the practice. It is not the direct effect of nitrous oxide. It is majorly because of the relaxation of the person, which will make them relieve the bladder. Nitrous oxide, is it safe for cardiac patients? Definitely it is, because nitrous oxide is not known to affect cardiovascular system. Even if a person who has hypertension or any kind of history of any kind of surgeries such as angioplasties or bypass surgeries or any kind of cardiac surgeries can easily go through nitrous oxide and dental treatment under nitrous oxide. Because nitrous oxide is not going to be eliminated through the liver or kidney, it is absolutely safe to be used with the people who are affected by either cirrhosis or renal failure and all those things, because it is one of the safest ways to do we still have time? Nitrous oxide effects of clinicians, not safe. I think we have addressed asthma is an indication for nitrous oxide. Asthma, contrary to what people might think, asthma is because of anxiety. Nitrous oxide reduces the anxiety. Number two, you are giving more oxygen to the person with the nitrous oxide and the oxygen combination. So nitrous oxide is actually an indication for people with asthma. How do clinicians protect themselves? I think we have answered that. Do we need an anesthetist? No, definitely you don't need an anesthetist. If you are trained dentist, going by regulations, you don't need an anesthetist helping you. How cheap are nitrous oxide machines? I would say how expensive are nitrous oxide machines? Roughly in my country, the machines would cost you somewhere about 2 lakh rupees to 4 lakh rupees. I don't know how much is it in Kenyan currency. That's how it is. You can do the conversion. I'm not sure about it. How can we repeat nitrous oxide for a patient requiring multiple settings? Yes, by all practical purposes, you are going to expect nitrous oxide eliminated from the body in about 10 minutes time. Theoretically, you can put back the patient after 10 minutes time, but you're not going to do that every time. You can put the same patient again tomorrow or day after tomorrow, but please be aware the number of times you increase and higher amount of nitrous oxide you use, you are going to have adverse effects such as bone marrow suppressions. But 2-3 times usage is not going to be of any disadvantage for the patient. With the COVID era, nasal hood is disposable. Yes, we do have disposable nasal hoods. I think we made a review article on use of nitrous oxide inhalation sedation. I think I'll share it a little later. You can take my email. If you send a blank email, I will share those articles with you, which is going to give you a little more awareness of use of nitrous oxide during this COVID periods. Suppose there is a leaking gas, maybe due to dislodged nasal. How safe is it to clinician breathing via nose? Nitrous oxide cannot result in any kind of acute ill effects. The ill effects of nitrous oxide are very chronic. That means if you continue to use nitrous oxide over a period of time, a period of weeks and months together, then you'll end up having chronic effects of nitrous oxide. Yeah, but if you are right next to the nose of the patient, if you are inhaling the nitrous oxide with the patient is exhaling, note you're also going to be happy along with the patient. But that is not going to be an advantage. Youngest and the smallest patient that can be treated, that depends on how well you can explain the patient to about use of nasal hood and breathe through the nose. I would say probably a 3 years old or 4 years old would be the age. Any child less than 4 years probably are not the appropriate patients for nitrous oxide. Oldest patient doesn't matter, as long as you can make a person understand. You can upper limit of the age is not a problem. Should we train the patient how to answer the, gestural means gestural, like, you make a story out of it. You tell the patient that I'm going to make a story. You have to respond only through your fingers. That way you can expect only gestural responses instead of verbal responses. Is it safe to use nitrous oxide in asthmatic patient? I think we have answered. Should we use the finger pulse oximeter or medical grade pulse oximeter? Frankly speaking, nitrous oxide inhalation sedation is the only form of sedation where you don't have to use electronic pulse oximetry. Clinical judgment of saturation is good enough, but a good medical grade pulse oximeter should be good, not the fingertip sports grade pulse oximeter. Avinash asked me whether oxygen concentrator present nowadays marketed. No, it is not going to clean nitrous oxide. Nitrous oxide should always be eliminated by literal physical sucking of nitrous oxide and released outside. It is not going to be nullified with in the room whatever machines you're talking about. What are the effects of good present? Oh, thank you. Airway in this kind. How is the safety of airway in this kind of sedation, cough reflux? Because cough refluxes, pharyngeal refluxes and laryngeal refluxes are protected with the nitrous oxide. So secretions will be swallowed by the patient or they will cough out. They will not go into the airway, so which is desirable. So that means a coughing patient is a good patient for you, because when he coughs, he's going to expectorate out. He's not actually taking it into the lungs. Can nasal hoods be replaced with the nasal prunes? No. The exclusive nasal hoods are the ones you need to use. Thank you for your presentation. My question is, we can still use nitrous on child with mild cold nasal blockage? Yes, but a running nose, when the patient has any kind of a running nose, is not going to be comfortable. Even without nitrous oxide, if you have to treat a child with a running nose, it's going to be extremely difficult, because the child will have laborious breathing through the mouth, and that child, I would not personally do any treatment on a child with a running nose unless I want to use a little decongestant, make it wait for some time and see some improvement, then probably you can go back. From what age can we use nitrous oxide? 4 and above, not less than that. Can you please comment on use of nitrous oxide for controlled asthma? Yes, indication, you can use it. Is recovery always 3 to 5 minutes? Maximum 5 minutes. It cannot be more than 5 minutes. Recovery from nitrous oxide is maximum 5 minutes. Same children go to sleep during treatment. How to monitor? Yeah, that's a nice question which you asked, whether the person is actually influenced of under nitrous oxide or sleeping. If you wake up the child and reduce the nitrous oxide, if you can see the patient coming back to the senses, that means it is a sedative effect. If the child is again going back to sleep, even when you reduce the nitrous oxide, that is the sleep. What I try to do is I take a 3-way syringe and just blow little gush of spray on the face so that the child will not will come out of the sleep. That's how I do it. How to adjust the flow, and that's a Rishabh, that is going to be a little longer explanation. That's a very reason why I didn't include that in the lecture. Probably I will share a video later. Anonymous attendee, do we adjust the nitrous oxide continuously? Yeah, you don't have to adjust it continuously. Once you fix it up to a percentage, you don't have to adjust it again and again. You know, you don't have to put your finger and keep adjusting it in and out. Once you fix it up to 30%, if you know that the patient is relaxed, and you can continue using 30%. What is the relation between noise and epileptic patients? In fact, nitrous oxide is one of the indicators for epileptic patients because it removes a trigger. Anxiety is a trigger. Number 2, it is going to relax the person. And number 3, it is going to give more oxygen than what the person is already breathing. So epileptic patient, it is indication. You can go ahead and use. Andrew asked me whether nitrous oxide can be used in mentally impaired patient. It can be used as long as you communicate to the patient and explain that, buddy, you need to keep your hood on the nose and breathe through the nose. If you can explain that to the patient, then retardation doesn't matter. The bottom line is your ability and child's ability or person's ability to understand your instructions. Is there any hypersensitivity involving nitrous oxide? Absolutely no. Like oxygen, nobody can be allergic to nitrous oxide. So absolutely no hypersensitivity. But any other sedative drug, you can have a hypersensitivity reactions. No, nil is fasting instructions to be given. No, fasting is desirable but not mandatory with nitrous oxide because the pharyngeal reflexes and Renin reflexes are protected. How long nitrous oxide can be done continuously? Probably you can go on till 2-3 hours time as long as you monitor the parameters. But longer you use, more adverse effects you are going to be, and you should be more vigilant. That means you can continuously use nitrous oxide for 2-3 hours, but when it crosses 1 hour, you need to be more vigilant. Why local anesthesia is a must with nitrous oxide? Nitrous oxide is a consciousness altering method, not a pain relieving method. So when you use nitrous oxide, we can reduce the amount of pain what you give with local anesthesia, but it will not be potent enough to extract a tooth. So you still have to give local anesthesia. Do enlarged adenoids affect the decision of nitrous oxide? Yes, it does, because it is going to be obstructing the nasal passages. So person with adenoids or enlarged tonsils will not be a right candidate for nitrous oxide. Diffusion hypoxia, I think it is going to take little time. It's beyond the moment. I can probably explain you in private if you can ping me a little later, because we are running short of time. Do we need to end procedure by decreasing? Yeah, that's a good question. As in fact, I didn't explain the proper mechanism of operating of machine. When you give nitrous oxide, you keep giving in the incremental order. You keep increasing by increments of tens. But when you decrease, you don't have to decrease in the decreasing orders. From whichever percentage, you can straight away go to 0% nitrous oxide, so that the person from any level will come out of sedation about 5 minutes time. Any research across how to change parenting styles impacting behavior? Yeah, one article which I shared, if you can show it, if you can throw your email, I will definitely send you those articles. Do you advise female dentist practice? Wow, that's a good question. I am specifically answering these questions. That's in fact a very intelligent question which is shot to me. Do you have an advice to female dentists? In fact, when you treat a female with the nitrous oxide, because of euphoric effects, the females will have little vulpurous effects. So they may even claim that there was some kind of abuse happened. So when I'm treating a female patient, especially when I'm a male patient, I always should have a female accompanies with the patient. If you can read the chapter on nitrous oxide by most of the textbooks, they will tell you about why you should have a female accomplice when you treat an adult female with nitrous oxide. Roller coaster effect is basically when you increase and decrease nitrous oxide up and down without waiting that time of 3 minutes, the person might feel pukey. That's called roller coaster effect. This is typically seen when you increase and decrease nitrous oxide in a short span of time. So you need to gradually ramp up nitrous oxide when you induce, and not up and down in a short period of time. That's when you see roller coaster effect. And the effect of this roller coaster effect is the person will start vomiting, or he will feel nausea and feel very uncomfortable to continue the treatment. That's about roller coaster effect. I think we have quickly could manage.
Yeah, we answered all the 100% queries. Thankful. It was a jackpot.
Yeah.
Thank you, Srinivas.
Thank you very much, Manisha. Any queries from your side, Dr. Gichu, from your society? I'm still open for questions through my WhatsApp or email. I shared my email there. I'll be more than happy to answer your queries in private through my email or messages or WhatsApp or Facebook, everywhere.
Yeah, no, I think all questions have been answered in the Q&A section.
My only regret is I wish I showed you the technique, but I'm sure I'm going to share your video, which is going to clear all your doubts about actual operation of the machine.
And hopefully we shall have you back once again to give us a lecture.
Yes, yes, yes. Yeah.
So thank you very much. That has been a very...
Yeah, I thank each one of you, especially Gichu, for following it up, hand-holding me.
You're most welcome. Thank you very much for agreeing to give us a lecture. It was very enlightening, and I think it's a topic that everyone is interested in. And I know in Nairobi as well, we want to start the practice of safe nitrous oxide sedation. So this has been quite something that we were looking forward to. So thank you, Dr. Priya, Dr. Manesh, and of course, Dr. Namineni, for organizing and facilitating this as the Federation of Special Care Dentistry. And to the Kenyan team, Dr. Kere, Dr. June, Dr. Ober, Dr. Mwasia, for joining us today as co-panelists. We thank each and every one of the attendees who came. And it's always an honor to see all of you here. So we will have a lecture next week on GA. Today we focus on inhalation sedation. Next week we shall talk about treating children under general anesthesia. So this has been a collaborative effort between the Federation of Special Care Dentistry and Kenya Association of Pediatric Dentists. And we shall invite you to join us next week, same time at 7 p.m. So have a good evening. For the Indian team, I know it's very late. It's 9 p.m. here. So we wish you all the best. Be blessed and have a good evening. Good night.
Thank you so much. Thank you, everybody.
Thank you very much. Thank you very much.
Stay safe, stay healthy.
Yes.
Good night. Good night. Thank you.
Good night.